My name is George Smith, and I'm an intern at the UT Health Medical Research Center, and I'm going to be covering the surgical and non-surgical methods of an anterior cruciate ligament tear. The anterior cruciate ligament, or known as the ACL, is one of a pair of the cruciate ligaments and is a key ligament for stabilization of the knee joint. It prevents the tibia from sliding up posteriorly from the femur and is located in the middle of the knee. An ACL injury is when the anterior cruciate ligament is stretched, partially or completely torn. Cause of injury can be from traumatic, from the lateral side of the knee, or overextending of your knee joint that can occur from abrupt stops and changing of direction during running, jumping, or turning. Knee swelling, instability, and pain are symptoms an individual may experience immediately after injury. The ACL injuries can be divided between 3 grades based on the severity of the injury. Grade 1 being the stability of the knee is kept, but the ligament is stretched. Grade 2 is partial tear of the ligament with the ACL being loose. And lastly, grade 3 is a complete tear of the ligament with the ACL being torn in two and with no stabilization of the kneecap. Treatment of an ACL tear can include immediate first aid onset of injury and can be followed up with either surgical or non-surgical treatment to regain function and stability of the knee. Other methods to alleviate pain would be to take medications such as ibuprofen or use a knee brace and crutches to decrease the amount of weight bearing on the infected knee. So the article that I'm using to compare the surgical and non-surgical treatment of ACL injuries is titled "Non-Surgical or Treatment of ACL Injuries, Knee Function, Sports Participation, and Knee Injury." The objective of the article was to determine the optimal clinical course between non-surgical and surgical treatment of ACL injuries. The article was published on August 6, 2014. So within the article, 143 patients with an ACL injury were divided within 2 groups known as non-surgical and surgical groups. Isokinetic knee extension, knee flexor strength, and patient-reported knee function was collected at baseline, 6 weeks, and 2 years, and sports participation was reported monthly for 2 years. Results were determined by analysis of variance, also known as ANOVA, generalized estimating equation, also known as GE models, and Cox regression analysis were used to measure the different functional outcomes, sports participation, and knee re-injury between the 2 groups. Patients in a non-surgical group completed a 5-week exercise program with a minimum of 2 sessions a week and a maximum of 4 sessions a week. The exercises performed by the non-surgical groups included quad sets, straight leg races, heel slides, and bridges. In conclusion, the crude analysis showed that the surgical group were more likely to sustain knee re-injury and participate in level 1 sports in the second year of the follow-up. However, the non-surgical group were significantly more likely to participate in level 2 sports during the first year and level 3 sports over the 2 years. Although there were few differences between the non-surgical and surgical groups for ACL injury, the results were not significant enough due to the considerable number of patients who did not fully recover post-ACL injury, and further studies should be conducted on improving the outcomes, as after 2 years, 30% of patients had extensive strength deficits, 31% with flexor strength deficits, 20% with patient-reported knee functions below normal ranges, and with 20% experienced knee re-injury.